Welcome everybody to our Discharge and Safe Transfer of Care collaborative session. I can't believe it, we're now on our 6th session, not quite sure where that time has gone by. I recognise quite a few of the faces here, but just in case I haven't met you before, my name is Ashley. I am the Network and OD, the Organisational Development Practitioner for Boost, which is our learning and improvement community. So what we're going to cover today, I'm going to do a very brief update from the last session, although if you weren't able to attend it, you will find on the Boost website, on the Discharge Collaborative page, you will find a recording of it if you're interested in catching up with that. We've got Anna Creber joining us today talking about the Primary Care Medicines Discharge Hub over in Sunderland, which is great. And then we'll do on the back of that a breakout room activity, looking at maybe how that process might be able to work in your area, what are the opportunities, and if there are obstacles, how could they be overcome? And then in the second part of the session, we'll then have a look at evaluating the impact of this collaborative, because we have come to the last of like the 6 sessions that we had booked in. So it'd be good to hear from yourselves in terms of, next steps forward for the collaborative, and if you would like to continue and kind of what you would like to get out of it. Very quickly, at our last session, we heard from Paul Carruthers, who was our Transfer of Care Hub Manager at North Cumbria Integrated Care Foundation Trust, and he spoke to us about co-production and the delivery of D2A pathways, and was sharing with us how they're using the third sector to help improve patient flow. And then the second half of the session, we were joined by Tom Duncton, who is the Commissioning Manager for the NHS North East and North Cumbria Integrated Care Board. And he spoke to us about virtual wards and about kind of making the most of acute care at home. So as I said, if you want to catch up on those sessions, if you weren't able to attend, you will find the recording. So without further ado, I am now going to pass over to Anna, who's going to talk to us about primary care medicines. Over to you, Anna.
Thanks, Ashley. Am I all right to share my own screen? Are you happy with that?
No problem at all.
Right, I'll be a couple of minutes. I'll just get my slides up because I think I have slightly tweaked them in the last day.
No worries.
If you can let me know, Ashley, when they come up, and then I'll start.
Yeah, we've
right?
got them now, Anna.
Yeah, brilliant. So my name's Anna. I'm the lead pharmacist for Sunderland PCNs. I work with Sunderland GP Alliance. I have a dual role, so I also work as a senior medicines optimisation pharmacist at the ICB, specifically in the Sunderland area. Are they moving on okay, Ashley? Yeah, brilliant. So I've been asked today to talk about a service that the PCN pharmacy team set up in Sunderland, where the pharmacy team, they action the discharge letters for the GP surgeries. So I thought I'd start with a bit of background about medicines during an admission to hospital. So during admissions, medicines may be stopped, started, doses may change, and medicines may be temporarily withheld. Short courses of medicines may also be started, for example, antibiotics and pain medicines. And when a patient is ready to be discharged, a letter is sent to the GP just to summarise what's happened during the admission. And as part of the discharge, there are changes to medicines listed and any actions for the GP to carry out. And a short supply of medicines is given to the patient. It's normally 1 or 2 weeks. So at the bottom of the slide, I've just put a definition of what medicines reconciliation is. I mean, I'm really aware of it as a pharmacist, but I know that everyone's got different backgrounds. So it's just really to kind of explain that. And it's the process of accurately listing a person's current medications. So it could be when they are admitted to a service or when the treatment changes. And I got that from the CQC website. So it's really important for a GP record to be updated with any medicine changes when a patient is discharged from hospital back to their care. So how did it start? So in Sunderland, there are 6 PCNs and they've got a large pharmacy team and we cover 38 practices. So the team work as PCNs, but they also work as a citywide model with SGPA being the employer of the pharmacy teams. The GPs and the practices had asked for the service to be developed. And this was because there'd been several incidents around medicines on discharge. So we started off by auditing 2 of the practices in Sunderland just to see what was happening and what they did when the discharge letters were processed. And what we found was there were delays in updating the medicine records and actions for the GP, and that was up to 63 days in some cases. So this can cause issues for patients. We found that numerous medication changes were missed and that the recording of allergies were also missed. And there were several occasions where short-term medicines to patients, short-term medicines were added to the patient's repeat medicine. So this is things like pain relief and laxatives where the patient don't need them for a long time. So they were prescribed them longer than what they were needed or they would go to waste. And we found that there was minimal communication with other healthcare professionals involved in patient care or the patient themselves. We also found that across Sunderland, GPs practices process discharge letters in lots of different ways. So some GPs, they did the discharge letters. In other areas, there was non-clinical administration staff doing it. And there was minimal clinical governance, really. So we knew that there were knowledge of errors, but very few were reported in the SERMS reporting system. So during the setup of the Medicines Discharge Hub, we agreed that our ambition was to reform the process for medicines reconciliation on discharge. We wanted to implement clinical governance within the process, and we wanted to provide a gold standard care for patients. And we also wanted to support practices in achieving the NICE Medicines Optimisation quality standard. You might be aware of them, but there's quite a few. And the one we were looking at was medicines reconciliation in primary care. So the statement is, let me just read it off. So it's people discharged from a care setting have a reconciled list of their medicines in the GP record within 1 week of the GP practice receiving the information and before a prescription or a new supply of medicine was issued. And we also wanted to support the practices with their CQC requirements, and that is to demonstrate that they had a process and clear audit trail for the management of information of changes to patient medications. So that's when we get information from other organisations, such as a hospital trust. So what we did in spring 2021, so it's been a few years now, we set up a task and finish group to decide how we were going to take it forward. And we looked at different models from a PCN level model to a citywide model. So the task and finish group, it had quite a wide involvement. So we had GPs, practice managers, prescribing clerks, the PCN pharmacists and pharmacy technicians. We also had the clinical directors and the GP Federation managers too. And the group engaged with hospital pharmacy and community pharmacy just to make sure we were on the right tracks. And we agreed really that the PCN pharmacy technicians would be best placed to lead the service. And we thought that they would be really good under the supervision of a PCN pharmacist. So we're just looking at like the right person for the job. And the outcome in the end, after several meetings, was a citywide medicines discharge hub. So it was working together for the 6 PCNs, and it was serving the 38 practices of Sunderland, and it opened in September 2021. So there were 3 phases to onboard the surgeries because we thought, we'd need to start off small and gradually add in the practices as we went along. So we started off with 9 practices just to ensure it worked, iron out any teething issues, and then we onboarded all the other practices. So this is just really an overview of what it looks like now. So we work Monday to Friday, 8:30 till 4:30, and we have 5 or 6 pharmacy technicians each day on a rota, and we have 1 clinical pharmacist per day. So that's really, really resource lean when you think of 1 pharmacist for 6 PCNs and all the discharges that are coming through from the hospital trusts. So in the last 12 months, we've processed over 23,000 discharges, and we set a target of 48-hour turnaround time. So this was just to make sure it was done in a timely manner and there were no delays. So it's 48 hours from when we received the document. So we've had no complaints. We have had 5 SERMS incidents where we have missed minor things, but this is of minor and no harm to the patients. And we've also reported in the last 12 months 20 incidents that we've picked up where there's been errors in other healthcare organisations. So it's really, really important just for learning and understanding. So just to get an idea of the service and how we were going to set it up, we visited another discharge hub in Newcastle hospitals. So they have a hub which they use with the PCN staff, but they're also integrated into the secondary care teams too. So they're set up completely different to us as far as I can understand. But they did help us work out our process, and then they've come and visited ours once we were set up to see if they wanted to change any of their processes based on the differences really. So it's been really good to collaborate with them. We developed a single process, and we did write SOPs just to provide quality assurance really. And we wanted one process that supported medicines reconciliation in an accurate and timely manner. And we wanted to improve communication with patients and the carers too. And we also wanted to support care home staff for the patients who are care home residents, and support community pharmacy, especially in the patients, you know, where they have the weekly medicine boxes, they're called medicine compliance aids. That can get really complex, so we really wanted to support that process. So this is the process on the page, and I'll just talk you through it quite quickly. So the discharge document that is sent from the hospital is then sent to a pharmacy inbox in EMIS. So it doesn't require a setup of any new system. It's all carried out in the same GP system. And this can happen because the PCN team are part of the practice team. They work on EMIS and as part of their everyday role. So the technician will then read the discharge in full. They'll carry out any like medicine changes, so medicines reconciliation, how I explained it before, and they update the GP medication list. You know, as I said before, medicines may have started, they may have stopped, there may be a short course of antibiotics, and we do add these as short courses onto the system just to identify any interactions, things like that. And then they identify any follow-up actions for the GP practice that wouldn't be carried out by the hub. They contact the patient, and then they contact the community pharmacy, the care home as well. But the care home obviously wouldn't be for every patient, it would just be for the ones who are residing there. And then after we've contacted everyone and we've had all the discussions we've needed to, we document a summary in the GP record using a standardised template that we developed for the service. We then order any bloods that are required, because a lot of patients do need additional bloods 2 or 4 weeks after they've come out from hospital, just to monitor progress. And then the pharmacy technician finally writes a summary task and sends it back to the admin team at the practice. And this just kind of reiterates again any follow-up actions that the GP may need to do. So it's things like they may need to monitor the blood pressure of a patient in 4 weeks, or they may need to increase the medication in a couple of weeks. So this is this slide just shows an example of the EMIS template. It is a test patient, so there's no worries with data protection and things. So the template helps the pharmacy technician process the discharges in the same way each time. It prompts them to find information in the discharge letter that's really important, and it summarises for the GP. And we also write there any follow-up actions that are still required for the GP to organise. So it's really well understood by the GPs now, because they're used to seeing this template. However, it doesn't stop the GPs going on and reading the discharge letter themselves. We don't want to take any care away from what the GPs do and support for the patients. And what I didn't mention in the last slide as well is the pharmacy technician. I probably should have added it to the flow diagram, but they try and synchronise the medicines to help the patient order the medicines on a monthly basis and reduce medicine waste. So that's a really positive thing that we can do as the medicines experts of the primary care team. So I've just listed some of the benefits really, and I think these are the most important ones. And I think the first one is that it saves GP and practice staff time. So we did do some calculations around the average time it would save for a GP, and we worked out it was 3 to 4 hours per week. However, we knew that some GP practices don't use GPs at all, they use admin staff. So it would vary for each practice, but it was just to really kind of get an understanding of how it was working after 1 year of the project. But even if it doesn't release GP staff time, it does release other staff members. And this includes pharmacists as well, because a lot of the pharmacists were carrying out the discharge letters before the pharmacy technicians took over. So that really releases their time to support with all the more complex kind of issues. And then we carried out data collection around cost savings of medicines, and we found that we saved around £2,500 over 4 weeks in medicines that we didn't need to add to the discharge, so that the medicines that are not for long-term use. And this amount was saved, you know, if the medicines were only prescribed for 1 month only. So we know that once medicines are prescribed, they're sometimes prescribed on repeat for 3 to 6 months. So you could extrapolate really for a 12-month period and look to see if each medicine was prescribed for 3 months. But it's just to give an average really and see that we are kind of cost saving. And we've seen this in prescription data as well, because there has been a reduction in the number of items prescribed in Sunderland at the time. We're in negative cost growth at one point, with less items being prescribed each month. So that was really positive. And I think we're currently not as negative. We're probably more of a positive, but we're still the lowest area for percentage item prescribing in the North East and North Cumbria. So we're still happy with that. Patient communication is 100%. So we contact the patient either by a text, if it's simple discharge, just to let them know that it's been updated on the GP record, or if we think it's really complex or the patient might need support, we give them a call and just check that they know what they're doing with the medicines. And the hubs, it's improved communication with other healthcare organisations. We send a summary document of medicines to the community pharmacy, and we support with any questions they have. And the team also have access to the hospital patient records, Meditech, for one trust only, just for the Sunderland and South Tyneside. But that means we can log on to find information if we've got a question from reading the discharge. So it means that we don't have to call the ward or call the pharmacy just to kind of clarify things. So it has reduced the number of calls. We've also got a resilient team, because we've got 19 technicians on a rota basis, so the service hasn't been impacted by annual leave or illness or anything like that. We've got a really high accuracy rate, and we've calculated that based on the number of incidents we've had over 12 months, based on the number of discharges we've also carried out. So it is over 99.9% accurate. And we've also supported improvements in the discharge process as well. So if I give you an example, one hospital in the region, we found out that we were regularly receiving multiple discharges for the same patient for a single admission. So we fed that back to the trust, and we found out that it was an actual processing of their system, so an IT issue. We had a meeting with the IT team at the trust, and to show them what we were doing on our side, what we were receiving. And they've gone away to currently look for a fix for that. So hopefully, it's a positive outcome for everyone. And just finally, on the benefits, the service is technically funded through the primary care network additional roles reimbursement scheme, the RS scheme. So it's at limited cost to practices or the ICB. However, they do have to use their resources for that. So it may impact other activity that they want to carry out. So I just wanted to talk a little bit about clinical governance. So when the technicians, they start to work in the hub, they undergo competency-based training, and they complete an accuracy log before being signed off. We also have oversight by a clinical pharmacist. So their role is to support the pharmacy technicians with questions around medicines that are beyond their competence. They'll be checking for interactions for new medicines, It can be anything really, just anything that the pharmacy technician does need support with. And the pharmacist also carries out spot checks for accuracy during the day, and they complete a log so that we can see that we are continuing to be accurate, and it's really good for quality assurance. We have standard operating procedures, which we love in pharmacy. These have been collectively produced with the GPs, and they've been reviewed via a clinical governance process at the GP Federation. And the team are really encouraged to report any incidents or errors. For example, occasionally the discharge letter may not be accurate, or there may be some miscommunication between secondary care and primary care. So we do try and promote reporting for learning. We have a review meeting of any incidents that have occurred in our team, although very, very low, on a monthly basis. And we have a learning meeting at least annually with the pharmacy technicians, so we can, review, reflect, learn, and we can change our processes if we need to. So just wanted to give like a couple of examples where the technicians have picked up errors, if everyone doesn't mind. So the first one is there was an incorrect dose of metformin on discharge. So metformin is a diabetes medicine, and that was picked up by the technician in the hub. They contacted the hospital pharmacist just to double check that the dose had been written wrong, incorrectly, and then they corrected the dose and completed the serums. The second one was atorvastatin used to lower cholesterol. So it had been recently stopped in primary care by the GP, and that was just to raise blood results. The patient went into hospital for another reason, and it was started by accident again. That was picked up again by the technician on discharge because they could see the GP record. So we stopped it after discussion with the hospital and the pharmacist, and we realised that, yeah, it was restarted in error. And the third one is around a controlled drug. So it was a buprenorphine patch, and that had been prescribed at a higher dose on discharge than what the patient was currently taking. So that had been picked up by the technician and corrected, and the incorrect patch had been returned to the community pharmacy for destruction. Just a few examples. So I've just put down a few of the issues that we've encountered, because it's good to see both sides of the story. Only 31 out of the 38 practices in Sunderland signed up, and the reasons we've received is that they have their own good discharge letter process at the practice. They're unsure of the new service and the new roles, and they're still not onboarding with 2 years of data. We've provided reports to Sunderland about the accuracy rates and the resilience, and how it's going so well. So because of this, we do have to organise rotas to ensure the practices who are not in the hubs have like a fair share of the technician time each week. And then we've discussed, setting up similar services elsewhere in other areas of the ICB. We've had like lots of visits from different pharmacy teams looking at it. But what we found is primary care is set up differently in each area, so it's really can be difficult to set up a similar hub. We're quite lucky that we have all of our PCNs under one employer, all the pharmacy team. I know that Tees was setting up a discharge process for care home patients, and I know that this is like a little different to Sunderland. So we do have also variation in daily numbers of discharges coming through as well. And we've worked out this is probably due to things like NHS strikes, staff shortages, but we do have resilience in the team, so we can support where we need to. And we found as well that if secondary care implements any processes, it can have an impact on the hub. I mean, it would have an impact on primary care anyway if the hub wasn't there. But we had a recent example where one of the trusts set up a split discharge process, and it was developed with the advantage that the medicine list would be sent ahead of the rest of the discharge from the ward. And this was just really to help get the medicine changes action quicker. So a really positive idea. However, we needed the narrative behind the changes to the medicines to action the discharges accurately, and it gave us double the workload because it was double the documents. So it increased us to beyond our capacity. So, we've fed this back to secondary care, and it did get sorted, and they're currently reviewing the process. So it's just really good to work together and kind of communicate. any effects of any changes to practice, really. So this slide, it shows some of the feedback we've received from our hospital and community pharmacy colleagues. I won't pause too long on it, and I won't go through it in detail, but I think the slides, Ashley, are they going to be shared afterwards? I think she's going to nod. Yeah.
Yeah, they will be.
Yeah, so you can have a look at what they've said. We've also carried out practice surveys as well, so we've had really good positive feedback excuse me, from the GPs. So I'll give you a couple of seconds to read. But just to summarise, their kind of thoughts were around releasing capacity, the timely management of discharge letters, and also around patient safety. So really positive. And we also carried out a patient survey because we like our feedback. So it was really good to see that I think it was over 96% of respondents felt extremely or very confident about the medicines after the phone call. So we only got feedback from the patients where we spoke to because we thought this was the most benefit, and that was compared to 45% before the telephone call. And we found that over 95% would recommend or strongly recommend the service to family or friends. So there's lots of other comments on the slides, and we've not really had any negative feedback from anywhere. So just a few slides really to summarise. I feel like I've rattled through it a bit. So just wanted to talk about the gold standard of patient care and how we feel like we've achieved it. So we feel like the service has reduced the previous delays in medicines reconciliation on discharge. That's just from a primary care point of view. But it means it can be, confidence from everyone that the GP record is up to date, it's accurate. And it supports the medicines optimisation agenda, really. And we wanted to find out if there'd been any change in readmissions, especially in admissions called by medicines, because we do know that you do get a lot of admissions due to medication errors. So we did receive some preliminary data from BI, and it was comparing two practices, one that was in the hub and one that wasn't. And it did show a lower readmission rate in the practice who was in the hub. However, we're finding that readmission rates are kind of going up across the patch anyway, and there's lots of confounding factors of why patients are readmitted to hospital. So we would really need further data, which we don't have at the moment, to really draw any further conclusions around that. We feel like we've improved patient contact because we do try and we contact patients either by telephone or by a text, so that's at 100%. And we do use SOPs, so we're standardising the way we work, just to ensure that medicines are not prescribed inappropriately. So a couple of examples of this is we try and encourage patients to self-care when it's appropriate. So we encourage them to, buy medicines over the counter in line with NHS England guidance. We also ensure that any high-risk medicines, so things like opioids, warfarin, DOACs, and shared care medicines, are second checked by a clinical pharmacist, and that's just to, to make sure that everything is correct and there's no other issues. And we also ensure that any under 16 years of age discharges are processed by a clinical pharmacist. And we just think that, there's lots of complexities, things around the doses and changes in paediatric population. So we're just trying to mitigate a bit of risk there as well. So, just to summarise, we really feel like we've achieved our ambition of a standardised, but I think we're quite flexible medicine reconciliation service. We've got clinical governance in there, and we just hope our processes can be used to replicate similar services elsewhere, really. And our main drive is improved patient care. So if anyone did want to get in touch and talk about it in more detail or wanted to come for a visit, I'd be really happy for you to do so. And that's the end of my presentation. Thanks. Has anyone got any questions?
Thank you so much, Anna. Oh, lovely. Oh, Jane's put her hand up. I was literally just about to read Jane's questions. I don't want to come and speak, Jane.
Yeah, sorry, I can't put my camera on at the minute because I look horrendous. I've got a terrible cold. Yeah, and I'm sniffing all the soil. I just want to know who authorises the number of issues. So when you put them onto the patient's records and it's something that's going to be a long-term medication, how do you authorise the number of issues or the med rev to coincide?
You mean who decides on how many months?
Yeah.
We would follow, the technician would have a look to see what would be most appropriate. So say they're already on like repeat medicines and it's a 6 monthly issue, then they would probably follow what's already been happening. If there was any concerns around having them for like longer, or if they need a review sooner, then they wouldn't. So say we are starting a blood pressure medicine, but we know we're going to need a review in a month, we wouldn't put it on repeat. We would wait until that blood pressure is checked, and then we would review it.
And then do you get a recall back to the hub for them to review
it? Queries, the pharmacist would make the decision. No, the hub only does the discharge as a one-off thing, and then it hands it back to the practice. So it's just a one letter thing. We do occasionally, if we feel that the patient's got some medication issues. So say we think, oh, they could be improved, or we've got questions around the medication, we send a task to the PCN pharmacy team and we say, could you carry out a structured medication review or a medication review? If we pick anything else up that we can't handle on the day, we do hand it to the right person in the team to have a look at that. It might be the GP, it might be a pharmacist.
Thank you.
Yeah, thanks, Jane. Is there any other questions for Anna? No, I think that's everything. Well, thank you so much, Anna, for coming to speak. I really do appreciate it, and well done to you and the team. Those benefits are fantastic, and that patient feedback is amazing. So yeah, really well done. Fab. Right, so what I'm going to do now, guys, is I'm just going to re-upload the slides, and then we've got a bit of a breakout room activity for you on the back of Anna's presentation. So they're just loading now. They're taking a while, as always. Bear with me. Ooh, let me get to it. There we go. Okay, guys, so what we're going to do now is pop you guys into probably a couple of breakout rooms, and we would like to find out from yourselves, how do you think a process like this might be able to work in your area? What are the opportunities, and if there are any obstacles that you guys come up with, how could they maybe be overcome as well? So my lovely colleague Suzanne is just setting up the breakout rooms for me now. Lovely. I think they're nearly ready to go. So we'll give you guys kind of sort of 15 to 20 minutes. We'll keep you updated with the timing as well while you're in there. So hopefully we'll be opening the breakout rooms any second now. So does anybody want to feedback for room 1? Any thoughts?
Was I in room 1?
You were.
No, which was
Anna. It ended up only being one room. So you guys are all very special.
Oh, there we go then. I don't mind feeding back if you want.
Lovely,
but
Anna.
It might be that someone else wants to, because I've done a lot of the talking on this meeting. So it was really interesting because Jane, who was on the call, was telling us about the hubs that are in North Cumbria.
Okay.
So they're at PCN level rather than like a citywide model.
Okay.
And it was really useful for, I think, both Angela, who works in Tees, and myself to kind of understand their processes. Because Angela was saying, with different employment models, that's the kind of barrier to having like a really large kind of citywide or Tees-wide hub, because it's just really difficult to get everyone on board with how it's going to work and things, really. And then we discussed fluctuations in numbers of discharges, because every day is a bit different, and Angela's got quite a lot of experience with one of the hubs that they've set up in teas, so it's just, you know, kind of managing like workload and having a backup plan. And then we talked about having access to the secondary care records was really positive, and that was a bit of a game changer because obviously it would allow, you know, less calls and communication. If you can go and just read what's been happening during the admission, it answers all the questions. I mentioned about
it makes it much more seamless, doesn't it?
Yeah, exactly. So you can kind of get an understanding, or at least a bit of background before you make that phone call. And then I mentioned about virtual wards and how that kind of is an up and coming kind of NHS service, and how we've been trying to, you know, work and support the practices in any changes that it might have on discharges and transfer of care and things. And then I think finally we were talking about, you know, the PCN DARES, so just the spec of that really, that technicians, it is in there that the technicians would be doing medicines reconciliation, so it's kind of a standard activity really that you would expect a technician to be able to do as part of their role when they're funded under ours. Can you think of anything else, Angela?
Oh, I think you've covered all the things we discussed there, Anna. I think yeah, for me, that the fact that you know, we've tried to replicate a citywide or a geographical area-wide. It is the difficulty in the different funding streams or how people are employed and who the host organisation is. But I think it's really interesting to hear what Jane's done in North Cumbria, and that definitely could be a future model where you share best practice processes and procedures with the PCN teams who have got staff that are employed under ours, and it is in their jobs, in their service spec to be carrying out that service. So I think that could be a really good model forward. But again, we were saying about the access to the notes is key, because we just waste so much time as a system chasing people around to try and get an answer to something that is probably written in black and white somewhere.
Yeah, no, really good point, Angela. Really good point. Brilliant. Lovely. Any other thoughts? Anything anybody else would like to add? Lovely, brilliant. Well, thank you very much. And once again, thank you so much, Anna, for presenting and sharing what you guys, you and your team have been up to, because, you know, it's clearly working really well. And, you know, it was great to see, as I said, those benefits that it was providing. So, but definitely, hopefully scope to, you know, take some of that learning and replicate it in other areas. But great to hear that North Cumbria has something quite similar as well. So fab, lovely, thank you. So I'm just going to re-share my slides a second. Unfortunately, it might take a little bit of time. Here we go, it's coming. So as I said at the start of the session, we are now at our sixth session, and kind of like the final one in the block of meetings that was set up for this collaborative. So it'd be really good to take an opportunity to kind of evaluate the impact the collaborative has had so far, and kind of get a better idea from yourselves of what opportunities you think there might still be available for the collaborative, you know, and if you think it's something that we should continue doing as well, you know, in terms of kind of scoping that commitment from yourselves. But I thought I would just take a very quick recap first, just to kind of remind us, because, you know, as I said, I don't quite know where the time's gone by, but actually, you know, we've heard from a lot of different people and achieved quite a few different bits and pieces. So from what you guys said right at the start, if you guys can remember, you wanted a directory of members, and that has now been created. We also have a WhatsApp group running. And then we've heard from the following speakers. So we had Catherine and Rachel join us from South Tyneside and Sunderland NHS Foundation Trust. They shared with us around community-focused care and how they were working together with education and enhancing the patient journey. We also had Kerry Evans come along, and I know she's had some meetings with some of you on the back of her presentation. So she was from the NHS and Care Volunteer Responder Scheme, and was thinking about, how we might be able to increase capacity to support discharge by using volunteers. We also then had Kelly Coulter, who shared with us about utilising personal health budgets and how they can support discharge. And then in December, we set up a retro board. And at that point, we then agreed on 3 themes to kind of focus on as a collaborative, which were the role of the third sector, virtual wards, and also looking at drug changes on discharge. And then those 3 themes basically have informed, the speakers we had at the last session with Paul and Tom, and then Anna today on the medicine side of things. And just very quickly want to flash up for you guys our agreed purpose, and this is basically just a quick reminder of what you said you wanted to get from the collaborative at the start. I'm not going to read that out. I'll let you guys read that on your screens. But just a reminder as to kind of what we set out at the start that we wanted to achieve with this collaborative. So what we're going to do now is pop you guys into probably just one large breakout room, because we're a little bit shorter on the ground today, which is a shame. But really, this is to kind of, scope from yourselves, what does this collaborative mean to you? What do you want from it, I suppose? Do you want to continue kind of, as I said, scoping that commitment piece out? So it would be great to hear from yourselves, what's been the impact of the collaborative so far for yourself? And what are our opportunities in terms of the future and next steps? So I thought it'd be best maybe to use our retro board as a way of kind of capturing that. So I think Suzanne's going to pop the link to it in the chat box for us. You might be able to click on that link as well. Now, oddly, I don't know why, but in the last day or so, it's asking you to sign in, and it never asked to do that before. But if you refresh the page, it should let you in. So it'd be good to hear from yourselves if you can manage to get on it okay. Fingers crossed. Oh, Angela, are you on it?
No, I'm not on it yet. I'm just
No.
I just wondered, it might only be me. I don't know the reasons the collaborative was set up originally. What was the driver for that? Because I don't know whether Anna's the same, but we were kind of, you and obviously got the information about the meeting and said, would we be able to attend? We're not sure what the key drivers were for setting up the collaborative and where the funding comes from, what the background is to the collaborative. So it's hard to say whether
of
think
course.
it's met it.
I understand that. I mean, ultimately, the collaborative was literally designed to be, like a community of practice, basically. So in terms of the funding, it's literally obviously just me facilitating it, I suppose, as part of Boost. But really, it was that agreed purpose that was kind of brought about. So, it was very much around, sharing, learning amongst one another, connecting people together, building those relationships, looking at ways in which we can share good practice, and testing out ideas. So that was kind of, the reason as to why the collaborative was set up, and the kind of drivers for it. Suzanne, did you want to add to that?
Yeah, I'll come in. So it originally stemmed from the first meeting of the Learning and Improvement Community, which was in September 23, I think.
No, it must have been earlier than that, Suzanne.
22?
It must have been.
Yeah,
22.
Oh, honestly, my memory is terrible. And that was held at St James's Park, so it brought an awful lot of people together from across the system, from different sectors that support health and care, and they identified 7 key priorities from that event to be taken forward. And obviously discharge and safe transfer of care was one of those, alongside kind of look at, workforce requirements, potentially joining up workforce, also like a shared learning platform, children and young people's mental health. So they're all being taken off in different directions, and I think the collaborative, you know, has come together in this way as a result of the kind of the initial meeting that Ashley just talked about. So, but yeah, so the background of is it's been identified as a priority for a shared learning approach across the system from that original meeting.
Yeah, and then we held a discharge summit as well, and that was really the catalyst, wasn't it, Suzanne, to then have like how are we going to keep this kind of, you know, discussion and work ongoing, and that's where the collaborative was set up.
Thank you.
So yeah, so have people managed to get onto the retro board? Okay. Fingers crossed it's worked. Yeah, so you'll see on the left hand side, I've marked them in like a dark blue kind of color. There's two sets, so you know, please add your thoughts onto the retro board, because I thought it would then be a way of continuing to use that, you know, if you guys want to carry on going forward, as a way of kind of capturing that. So, you know, around opportunities, you know, think about if there's any, you know, topics or themes you might quite like to be covered in upcoming sessions, you know, and kind of, you know, what would even better if, I suppose, look like for the collaborative as well. So I will hand over to Suzanne to open the breakout rooms.
That's it. So
Okay, lovely. Okey-doke. Hello, welcome back. Oh, we've lost even more. What a shame. Okay, guys.
We did
So
know there were 2 rooms, but obviously not.
Yeah.
no, unfortunately not, but never mind, never mind. Thank you so much for filling in the retro board for us. I feel like it's great minds think alike, because we have got a survey that we're going to launch on the back of this, because obviously it was always conscious that, you know, even if, I don't know, 40, 50 members attended, we've got like about 150 people, I think it is, on our collaborative list. Yeah. So, you know, it was really important that we heard from, you know, everybody had the opportunity to kind of give their feedback and things like that.
Yeah.
But yeah, thank you so much for filling that in. And then in terms of, I think you said there about the membership list. So some people have kind of like consented to put their details on our membership list. So if you guys would like access to it, just let me know, basically drop me an email. More than happy to share that with those that I said have kind of consented for their information to be shared. So yeah, lovely. Right, I might not even pull the slides up, to be honest with you, because I know it can take a little bit of time, but just to let you guys know. So yeah, so if Suzanne, you could pop the link to the survey in the chat. I will be, when I email out the slides and everything, I'll be sending out the link to the survey as well for everybody to complete, to hear, yeah, what you guys think sort of so far and next steps as well. And then also, just to let you guys know, we have a lunch and learn session coming up on the 18th of April around improvement. So it's Zoe from Barnsley Hospital that they've improved an admission to discharge process. So she's going to come along to that session and share that. So just to let you guys know about that as well. And then, yeah, so kind of going forward, we'll let you know the results of the survey evaluation, and then look hopefully to book some more sessions of these in coming up. But